Good day everyone. These are 116 slides in preparation for your practical orthodontic exam prepared by Professor Akram Alhuwaizi from the Department of Orthodontics in the Baghdad University. We've broken down the presentation so that it's of 20 parts, and the first part is regarding orthopantomographs. Now orthopantomographs are the first question you'll be asked is age. And keep in mind, if they specify a boy then a girl, then a boy is about 6 months older than a girl regarding the same dentition. So if you have the 6s erupted and the lower incisors, then this boy or girl is 6 to 7 years of age. Since this one has the lower lateral incisors and the upper central incisors erupted, so he's about 7. The next slide have the laterals erupted, so they're about 8, since these are not really fully erupted. But if they were fully erupted, then they could be 8, probably 9. But at the age of 10, then you've got the eruption of the canines and the 4s here, but still there's no eruption here, so this patient is around 10. And if these have finished and just the canine is left, it could be around 12, probably 11. And finally, if the patient has a full dentition, with the exception of the 8s, then the patient is well above 14, let's say. The other type of questions is the anomalies. What are the anomalies regarding the upper incisor region? And concentrating here, you'd notice that it's not the midline diastema that we're talking about, it's the congenitally missing lateral incisors associated with mesial drifted canines and the retained deciduous teeth. The anomaly here is the congenitally the impacted canine, this impacted maxillary canine. What's the most likely treatment option? Well, the treatment option is to surgically expose the canine and tract it downward. What is the anomaly? And you look at the anomaly here, it's supernumerary teeth in the premolar region. And what's the most likely treatment strategy? It would be surgical extraction of these teeth. What's the anomaly? And the anomaly here is impacted lower canine teeth. And what's the most likely treatment strategy? It would be also surgical removal of this tooth. What's the anomaly here? And you notice this tooth is a dilacerated central incisor which is impacted. And what is the treatment for it? Also, it would be surgical removal of this tooth. The second part is cephalometrics. And the cephalometrics here, then the common first question is to name the radiograph. The radiograph is a cephalometric radiograph. Give the class of malocclusion. You can notice from the increased overjet that this is a class 2 division 1 malocclusion. Name the points and define the points. Usually you get 2 per slide. And this slide sums up the various points which you would see inside the cephalometric radiograph. The other type of question is name the planes and define the planes, and usually also get 2 per slide. And the most common planes are the Frankfurt plane, mandibular plane, maxillary plane, the SN plane, the NA plane, and the NB plane. Name the angles and give the average values, usually also get 2 per slide. And these are the summary of the various angles with their normal variation also noted down. This is also the gonial angle. Now name the radiographic view and what's being used for. This is a cephalometric radiograph, and it's being used to assess the skeletal age. The third part is other X-ray views. For example, what's the radiographic image? It's an occlusal film. What's the anomaly? Supernumerary teeth. What's the type? It's mesodens, teeth that erupt in the middle of the maxillary arch. What's the radiograph? It's a wrist radiograph. What's it used for? To assess the skeletal age. Name the radiographic view. It's a periapical X-ray. What is the anomaly in B? It's root resorption. What's the radiographic view? It's a CBCT, or probably a CT scan. What's the anomaly here? It's an impacted maxillary canine. What's the associated complication with the maxillary impacted canine? It's resorption of the root of the adjacent lateral incisor. What's the most likely treatment strategy? Probably extraction of the lateral incisor and allowing the canine to erupt. And that's because of the severe resorption of the lateral incisor. The fourth part is concerning extraoral photographs. Now name the area 1 and 2. Area 1 is the midface and area 2 is the lower face. And in normal subjects, which one's larger? No one's larger. Normal subjects, they're equal in size. Name the photographic image view, and it's a frontal photograph. Name the anomaly. It's chin deviation or mandibular deviation to the left side. Give two possible etiological factors. Well, it could be trauma, condylar hypertrophy, condylar hypotrophy, cross bites associated with mandibular shifts. Name the photographic image view. It's a bird view or a top view. Name the anomaly. It's shifting of the mandible to the right side or asymmetry of the face. The fifth part is appliances and machines. Name the use. What's the name of this machine? It's a cephalometric machine, and it's used to make cephalometric films and OPG films. What's this machine? This one is a hydroflask, and it's used to cook the acrylic, the orthodontic acrylic, under pressure and heat so that it cures. What's this machine? This device is called a welder, and it's used for welding of stainless steel wires. Name the material and instruments. This one here is a torch, and it's used to give flame and heat for soldering. This one is flux, and it is used to remove the oxide layer of the wires during the soldering process. And this are the solder material. The sixth part is general questions, and these are regarding tooth movement. What's the type of tooth movement here displayed? It's tipping tooth movement. Which appliance can accomplish this? Well, removable appliances can do tipping movement, and fixed appliances can do tipping movement. What's the type of tooth movement here? And this is a bodily tooth movement, and it's only accomplished by fixed orthodontic appliances. What is the type of tooth movement here? And this is torquing movement or root movement. That would be more precise. And it only can be accomplished by fixed appliances. Okay, the distance here in A is overbite, and the normal value of it is 1 to 3 millimeters. And in B it's overjet, and the normal value would be from 1 to 4 millimeters. The case in A or B. Here in A it's proclined, where in B it is just protruded with an upright incisors, not proclined. Part 7 is extraoral appliances, and here name the appliance and the type. In A you've got a high pull headgear. In B you've got a cephalometric pull, and here with a face bow. So it's a high pull headgear with a face bow, and here it's a cephalometric pull. It's a cervical pull with a headgear, with a face bow. So name the appliance. The appliance is a headgear, hypo headgear with a face ball. And what's the mode of action? It pushes the molars backwards, either to enhance anchorage or to distalize the molars. Which malocclusion is it generally used for? A class 2 malocclusion. Name the appliance. It's a reverse headgear. What's the mode of action? It protracts the mandible, or the maxilla, forward. Which malocclusion is it used to treat? Class 3 malocclusion. Name the appliance. It's a chin cap. What's the mode of action? The mode of action is that it redirects the growth of the mandible in a backward and downward direction. Which malocclusion is it used to treat? Class 3 malocclusion. Part 8. Myofunctional appliances. Name the appliance. It's a Frankel 3 appliance. Which class of malocclusion is it used for? It's used for class 3 malocclusion. What is the optimal age for treatment? Around 8 years of age. Name the appliance. It's a monoblock or Andreessen appliance. Which malocclusion is it used for? It's a class 2 division 1 malocclusion. What's the optimal age for treatment in boys? Well, that would be around 10 to 11 or 10 to 12 years of age. Expansion appliances. Name the components of the appliance. Here, when you hear components, then you have to specify all the components. You've got the active component, which is the mid-palatal screw, the retentive components, which are the Adams clasps on the 6s and 4s, 4 Adams clasps, and the acrylic base plate, and the posterior bite plane. All of them are components. What's the action of the appliance? It's a reciprocal action to expand the maxillary arch. What condition does it treat? Posterior crossbites. Name the spring. It's a coffin spring. What's its mode of action? It expands the upper arch. Name the appliance. It's a Hyrax expansion screw. What's the action of the appliance? It expands the upper arch. What condition does it treat? Posterior crossbite. Same thing for this one. Also a Hyrax palatal expander. And name the appliance. This one is a quad helix appliance, and the mode of action is expansion, and it treats posterior crossbites. Name this one. The active component here is a screw, and the action of the appliance is to widen the mandibular arch. Name the components of the appliance and on which teeth they're seated. Here you would say the active component is a screw. The retentive components are Adams clasps seated on 6, 4, 6, and 5 with a fitted labial arch on 1, 2, and 2, 1. Don't forget to mention the acrylic. Which class of malocclusion does it treat? It proclines the upper incisors forward, so it treats class 3 malocclusion. Name the active components of the appliance, and it's just the mid screw. Name what's the action of the appliance? It expands the arch laterally. Removable orthodontic appliances. Now, what's the modification of the acrylic base plate? The modification of the acrylic base plate here is an interior bite plane. What's the action of the interior bite plane? It opens the bite so that the posterior teeth don't touch. What's the condition that it treats? Is anterior deep bite or deep bite. What's the modification here? It's an inclined interior bite plane. And why is that? What's the action of it? It opens the bite posteriorly, and it also positions the mandible in a forward position. What's the condition that it treats? It's deep bite with increased overjet. Name the modification of the acrylic base plate It's a posterior bite plane. What's the action? The action is that it opens the bite anteriorly. And why? So that it allows for the correction of anterior cross bites. Part 11. Removable orthodontic appliances. Now here, when we're talking about the components of the removable orthodontic appliances, I've gathered here the gauges of all the springs and the clasps and their gauges. Notice the difference that active components are what's called springs and the retentive components, which are called clasps. Sometimes howdy arches can become retentive and not active. The others apply the same. So Z springs are made of 0.5 mm hard stainless steel wire. Recurved springs, if positioned on centrals, are made out of 0.5 mm hard stainless steel wire, and if they're positioned on 4 teeth, they're made out of 0.6, etc. Finger springs, which are simple or guarded. Buccal canine retractors, which are either self-supported or sleeved. T-springs, howdy arches, Roberts retractors, which are also either self-supported or sleeved. And the retentive components are Adams clasps, fitted labial arches, C-clasps, and ball-end clasps. So what's the appliance used for? And you look at the active component, and it's a Z-spring here on the central. So it is correction of the anterior crossbite affecting this lateral incisor. Sorry, not central incisor. Name of the component of the device and which teeth they sit on. This is a Z-spring, which sits on the lateral incisor. This is a central Adam clasp, which sits on the central incisor. And this is an Adam clasp, which sit on 6 and 5, 6 and 5. This is an acrylic base plate, and this is a posterior bite plane. Note that this Adam clasp is very near to the Z-spring, so that it provides perfect anterior retention, which makes the Z-spring work perfectly. What's the appliance used for? In this case, you would notice there's a Z-spring and there's a howdy arch, so most likely this is designed to derotate an anterior tooth, probably the central incisor, and by a couple force system. Name the components of the device and which teeth they're seated on. On the 6s, there's howdy arches on both 6s, Adam clasps, and there's a howdy arch, and there's a Z-spring on the central. The gauge of the wire is 0.7, 0.7, 0.5 mm hard stainless steel wire. What's the appliance used for? To push the lateral incisor out to correct its crossbite. The components are Adam clasps on the 6s of 0.7 mm wire. Recurved, this is a fitted labial arch on the centrals of 0.7 mm wire, and the Z-spring on the lateral incisor of 0.5 mm wire. Don't forget, there's the acrylic base plate, since it's components, and here you would notice there's a posterior bite plane. What's the appliance used for? Retraction of the canines. Name the components, the devices, and the gauges. Here there's an Adam clasp on the 6s, also of 0.7 mm hard stainless steel wire, a self-supported simple finger spring on the canines, and it's made out of 0.6 mm hard stainless steel wire, together with the fitted labial arch on the central incisors, made out of 0.7 mm hard stainless steel wire. Name the active component, and it's a modified Z-spring. Notice it's a modified spring because of the loop here, which enables it to slightly distally move the tooth. Give the wire gauge. The active components, the retentive components are the Adam clasps on the 6s and on the 4s, and they're made out of 0.7 mm wire, whereas the Z-spring is out of 0.5 mm wire. It didn't say the other components, so there's no need to say anything about the acrylic, since it's not one of the retentive or active components. Name the two clasps and their wires. Clasps mean it's retentive. So we've got 6s which with Adam clasps, and their gauge is 0.7mm hard stainless steel wire, and the fitted labial arch made out of 0.7mm hard stainless steel wire seated on these centrals. On the right there's a buccal canine retractor, which is a sleeved type, so it is made out of 0.5mm wire, and it's a simple type. And on the left there's a finger spring made out of 0.6mm wire. Name the active components and the retentive components. The active components are the guarded finger spring, which is made out of 0.5mm hard stainless steel wire, seated on the canines, and on the 6s there's the Adam clasps, which are seated on the 6s, and they're made out of 0.7mm wire. The name the spring and what it's used for. This is a buccal canine retractor, the modified type, and it's used to correct a buccally positioned canine, maxillary canine. What is the gauge? It's made out of generally of 0.7mm wire, but for this gauge it's sleeved, so it's made out of 0.5mm wire. For this type, there's this question, name the active components. The active component is a T-spring. What's it used for? To push the upper 5 labially. What's the gauge of the wire? It's 0.7mm wire. Name the spring that's used here, and it's a Howley arch. The gauge of the wire is 0.7mm wire, and the condition that it treats is anterior over the increased overjet, which is 6mm or less. Name the spring and the type. It's a Roberts retractor, and it's a sleeve type. The gauge of the wire is 0.5mm, and the condition that's used to treat is increased overjet of more than 6mm. Part 12. Retainers. Name the appliance. It's a Howley retainer. What's it used for? It's the retention after the active orthodontic treatment. Enumerate the components. It's Adams clasps on the 6s, and Howley arch, and acrylic base plate. Name the appliance. It's a lingual permanent retainer or fixed retainer, positioned on the 1, 2 on the incisors, upper incisors, and lower incisors and canine. What's it used for? To retain the teeth after active orthodontic treatment. Name the appliance, and that's the overlay retainer, or the invisible retainer, or the vacuum formed retainer. And what it's used for as well is to retain the teeth after orthodontic treatment. What's the appliance A used for, and what's B used for? Well, B, we would notice there's trimming of the acrylic here, so this appliance is active, and it's in which we're reducing the overjet by retracting the incisors backwards. Whereas here, you would notice there's no trimming of the acrylic, so there's no active movement. So this is a retainer, a Howley retainer, yet this is an active appliance. Part 13, fixed appliance components. And here, name the appliance. It's a lingual orthodontic appliance. Give one advantage for its use, and that would be the superior aesthetics. What's the type of brackets being used? It's ceramic orthodontic brackets, and give the advantage for its use, and that would be also aesthetics. Name the auxiliary components. 1 is a coil spring, 2 is the type of attachment is a bracket, and 3, the type of attachment is a band. Name the auxiliary component. 1, it's a separator. 1 is a ligature wire, and 2 is a separator. Name the auxiliary components. 1 is a ligature elastic, and 2 is a coil spring. Name the elastic components. 1 is an intermaxillary elastic and 2 is a cross elastic. Name the elastic components. 1 is a power chain or an elastic chain, and name the attachment component. 2, it's a button. Name the type of intermaxillary elastic. In A, it's a class 3 elastic, which pushes the mandible backward and the maxilla forward, and B is a class 2 elastic, which pushes the mandible forward and the maxilla backwards. Name the components 1 and 2. 1 is a transpalatal bar or transpalatal arch, and 2 is a lingual bar. Give the name of the appliance. 1, it's a lingual bar, and 2, it's a banded loop. What's their use? They're used as space maintainers. Name the component, and it's a temporary anchorage device or a mini screw, and give 2 possible uses for it. It could be intrusion of molars or retraction of incisors. Part 14, Malocclusion Class. Now here we're going to be asked about malocclusion class. What's the malocclusion class of this patient? And that's a class 2 division 1 malocclusion. Give 3 malocclusion features like deep bite, increased overjet, anterior upper and lower spaces. Give the malocclusion class of this patient, also class 2 division 1 malocclusion, and the same 3 malocclusion features. What's the malocclusion of this one? It's a class 2 division 2 malocclusion, and the 2 malocclusion features, deep bite and retroclined upper central incisors. Name the malocclusion class would be class 3 malocclusion. Give 3 malocclusion features would be posterior crossbite, anterior crossbite, upper crowding, lower crowding, reverse overjet, etc. Name the malocclusion class. Here the patient can bite edge to edge, but is forced to bite in an anterior position where there's a reversed overjet, so it's a postural class 3. And what's the age of the patient? We look, the patient has only 4 incisors here erupted and here erupted, and the others are deciduous, so the patient is around 8 to 9 years of age. How do we treat it? By just pushing the upper centrals forward so that the patient can bite normally. Name the malocclusion class, and you notice here on the molars, it's a class 2 molar relationship with probably class 2 canine as well. So it's a class 2 malocclusion. 3 malocclusion features, and that would be anterior open bite, crowding, and the posterior crossbite. Give the canine classification of the case, and that's going to be a class 2 canine relationship. What's the definition of a class 1 canine relationship? It's a relationship where the tip of the upper canine is engaged in the embrasure between the lower 3 and 4. Part 15, crossbites. Name the malocclusion. It's posterior bilateral posterior crossbite. In which case is treatment better done by maxillary expansion? It's in case 1, where there's constriction of there's lingual tipping of the molars. So expansion here works better than here, where they'll be proclined. So this one, the answer. This is better treated by expansion of the arch. Name the malocclusion. It's bilateral posterior crossbite. What's the best treatment strategy for this condition? It's to leave it alone and not to expand it, because it will not be stable. Name the malocclusion. It's scissor bite. Give a possible etiological factor. It has to be genetically, the mandible is very small, and that's why you get the scissor bite. Name the malocclusion. It's true unilateral posterior crossbite. Possible etiological factor could be trauma from early age, And what's the best treatment strategy? Would be either to accept it or to treat it surgically, since orthodontically tipping the teeth will not solve the problem. Name the condition below associated with crossbite. The condition, you notice the maxilla, the mandible is shifting so that it gets maximum intercuspation. So this is lateral mandibular shift associated with the unilateral crossbite. What's the best treatment modality? It would be expansion of the maxillary arch so that we get a cusp to fossa relationship. Describe the malocclusion. Well, it's posterior crossbite with anterior crossbite with peg-shaped laterals. Name the condition in case 1. The condition is a buccal crossbite. And here it's a lingual crossbite or a scissor bite. Name the condition below associated with the crossbite. Also, the condition here is similar to that one. It's an interior mandibular displacement associated with anterior crossbite. Name the condition. It's a crossbite of the upper central incisor. And what's the complication? It's this central incisor. There's trauma to occlusion that's happening to it, and there's gingival recession as well. Name the condition. It's scissor bite, which is affecting the upper right second molar. What's the elastic that you can correct it? It's cross elastics. Part 16 is open bites. Name the condition affecting the anterior teeth. It's anterior open bite. Give the most likely etiological factor. The most likely etiological factor, because it's asymmetrical, would be digital sucking. Name the condition affecting the anterior teeth. Anterior open bite. Give 2 likely etiological factors. Well, since it's symmetrical, it could be tongue thrust, it could be skeletal open bite because of vertical overgrowth. Name the condition affecting the posterior teeth. It's lateral open bite. The possible etiological factor could be a large tongue. Part 17 is crowding and spacing. Give 2 features of this malocclusion: deep bite, upper crowding, and lower crowding. Name the condition affecting these teeth. It's crowding of the teeth. Give 2 possible etiological factors. It could be because of the small jaw or large teeth, a disproportion between the teeth size and the size of the jaw, or it could be because of mesial migration of the sixes, because of early loss of deciduous teeth. What's the condition affecting the lower incisors? It's crowding. And what's the age of the patient? The patient would be from 8 up to 10 years of age. Name the condition. It's buccally positioned canines with crowding. What's the treatment of the condition? It would be extraction of 4 units for the patient and using orthodontic appliances to correct the malocclusion. Give 2 malocclusion features. That would be a median diastema and peg-shaped lateral incisors. Name the condition. This is a generalized spacing. It's not just a median diastema. And the most common etiological factor is small teeth associated with a larger arch. So it's a discrepancy between the arch size and the jaw size. Name the condition affecting the central incisors. It's a median diastema. And the etiological factor is a thick frenum. Name the stage of development of occlusion, and it's an ugly duckling stage, and the cause of the condition is the erupting canines pushing the roots of the incisors away. Part 18 is local factors. Name the anomaly affecting the lower incisors, and the anomaly here is not just crowding, but it's 1, 2, 3, 4, 5. There's a supernumerary supplemental lower incisor. So it's the type of it is supplemental. Name the anomaly, and here the anomaly is transposed canine and premolar. Canine and premolar. Part 19 is design a removable appliance. Design a removable appliance to treat this condition, crossbite of a lateral incisor. And the design should be, it will fall into active components, a Z-spring to push the lateral incisor. The retentive components, he has permanent teeth, so it's Adams clasps on 6s and 4s. Why the 4s? Because we have to have anterior retention with Z-springs. Active, the acrylic base plate, don't forget it, with the posterior bite plane. Optional components could be a Howley arch to control the proclination of the lateral incisor. Design a removable appliance to treat this case, and this is a case of a unilateral crossbite. So the design would be a mid-palatal screw, Adams clasps on 4s and 6s with posterior bite plane. Design a removable appliance to align the central incisors. This is a simple case in which you treat it by recurve Z-spring on 1 and 1 and the Howley arch. And the Howley arch here is active since it does a couple force system. The retentive part is the Adams clasp on the 6s and 4s and an acrylic base plate. The last part, part 20, which is miscellaneous, and it is related to name the anomaly. Here we've got congenitally missing laterals in which the canines have come in their place. Give possible treatment options, and the best treatment option would be to aesthetically correct the canines to simulate lateral incisors by using composites or other conservative type of means. Name the condition, and it's also congenitally missing lateral incisors, but this time with an open space, and the treatment is also conservative. Name the condition, and it's a canine erupting lingually, and what's the etiological factor? It would be because of the retained deciduous tooth. Now what's the surgical procedure? And this is transposition of the teeth in which you extract the C, and then the canine is also surgically removed and inserted and sutured and left in place until it heals. And name the treatment procedure, that's interproximal stripping, and this is done in mild crowding cases. Name the habit, and this is a digit sucking habit, and name 3 associated malocclusion sequelae, and that would be increased overjet, anterior open bite, and unilateral posterior crossbite. Name the appliance used, and this is a habit breaker with a tongue crib, and the conditions used for is to break digit sucking and tongue thrust. And thank you for your listening. I hope you had a valuable time listening to this video, and thank you for that. And if you have any questions, please leave them down in the comments below, and I'll hopefully answer you when I get a chance. Thank you again.